Hello? Okay, guys. How are you guys doing? How was your midterm yesterday? How many of you are so happy and ecstatic? Was it okay? Are you guys okay? Alhamdulillah. So this lecture is in two parts. Many of these concepts, the initial concepts at least, have been covered as recently as semester 2 in the HLS block. But I don't expect you to remember any of it. And we will do it like you don't know and I don't know. Oh my God, I'm getting recorded. Okay, so you know. Without further ado. Okay, these are the objectives. Discuss normal hemostasis, discuss functions of vessel wall, platelets and coagulation factors in bleeding, coagulation and thrombosis, clinically correlate defects of vessel wall, platelets and coagulation factors, and discuss pathophysiology of thrombosis and thrombophilic disorders. What is hemostasis, guys? Anybody? What is hemostasis? That's homeostasis. Yeah. So hemostasis is normal physiological response that can prevent blood loss when the vascular system is breached. So everybody bleeds after they have a trauma or something. But and then when we do bleed, the body's hemostatic responses, they come into play to stop the bleeding. And it is an interplay between three main things, which is the vessel wall, the platelets, and the clotting factors. These three things together constitutes the hemostatic system. There is no mic? Sensitive people. Nancy, can you hear me at the back? Okay. I will keep on disturbing you like that so that you don't fall asleep or something. I only know very few names. These are the ones who were with me during Aspire during summer. So the ones that I know, I'm not trying to pick on you or anything. I have to make sure that everybody is awake. But the problem happens, so that was normal physiology. We will discuss the normal physiology again anyway, but the problem happens if this system, if there is any problem with the system, either any problem with the vessel wall or any problem with the platelets, they can be low, they may not function normally, or they can get activated inappropriately, okay? Similarly, regarding the clotting factors, they can be low, they may not function normally, or something can activate them, which it should not, okay? And all of these things are going to lead to problems, right, in the patient. So we need to understand first the physiological concepts, the normal physiological concepts, and then take that knowledge and apply it in pathology. And that's what pathophysiology is. Now, as I've said, it is the coordinated response between endothelium, platelets, and plasma proteins or clotting factors. And the two main mechanisms are known as primary hemostasis and secondary hemostasis. If it's primary, then yeah, primary and secondary hemostasis. Okay, so it is a balancing act between the pro-clotting factors and the anti-clotting factors. We will discuss both of those. The main three things are endothelium, platelets, and the clotting cascade. And when all three things comes together, they lead to the formation of a thrombus or a clot. There is a little bit of a difference between thrombus and a clot. And when the time comes, either today or in the next lecture, inshallah, I will tell you the difference between the two. But for all practical purposes, clinicians all over the world use this terminology interchangeably. So in our eyes, thrombus and clot means more or less the same thing. So the first thing that happens whenever there is trauma is reflex vasoconstriction. So the blood vessel wall, it constricts, and this is mediated by number one, reflex neurostimulation and the release of endothelin by endothelial cells. So both these phenomena, they come together, the release of endothelin, which are released from the endothelial cells, and the reflex vasoconstriction mediated by neurostimulation in the vessel wall. Both of them leads to vasoconstriction. So this is the first response. And the purpose of this is to try and stop bleeding, or at least try and narrow the wound that is there so that bleeding can stop. So this is the first thing. This is the first step after any trauma. After that, And this is the first constituent. The vessel wall itself is the first constituent in the primary hemostasis. Now, the vessel wall has two roles. Number one, normally, normally, all these factors that you see here, they are there to prevent clotting of blood. We don't want the blood to clot normally. When it is flowing inside the body, we don't want it to clot, right? So there are a number of factors which are there and which are closely related to either the plasma proteins or to the endothelium. And the collective function of all of these factors is to prevent formation of a clot or the formation of a thrombus under normal circumstances. All of these things. I'm not going to go into the details. I will just give you some examples, things like antithrombin 3, there are activated protein C, and there are others which are all there to prevent heparin-like molecules, tissue factor pathway inhibitors. Some of these are going to come up in the later part of the lecture. So some of these will be covered. But the concept that I'm trying to convey on this picture is under normal circumstances, there are a number of factors in the plasma and that acts in coordination with the endothelial cells to prevent or inhibit clotting of the blood or formation of a clot. But whenever there is trauma, whenever there is breach of the endothelium, everything that you see here disappears. And the endothelium releases something. It actually releases two things. One of them is really important, and that is known as tissue factor. Okay, the life is not compatible without tissue factor. All tissues have tissue factor. So they are released. In addition to that, and von Willebrand factor is also released from the endothelial cells. And the function of these two is paramount in both primary and secondary hemostasis. So the release of tissue factor is going to start the extrinsic pathway, and the extrinsic pathway, we will discuss it in a minute, is going to lead to the formation of a fibrin clot. So suddenly, whenever there is trauma, whenever there is a breach of the endothelium, this is going to lead to release of factors that favor thrombosis or clot formation. Is this clear? Any questions? Okay. Now, the second step after reflex vasoconstriction is that the platelets, they come to the site of injury, the site of trauma, and they adhere to this site of trauma. So when they adhere or attach to the endothelium, we call it platelet adhesion. They also undergo a shape change. So they are rounded initially, but they become more flattened. And the reason they become flattened is they are there to provide a phospholipid surface on which the clotting factors can act. Okay, and I will show you in a diagram how that happens. So the second thing that happens after platelet adhesion is shape change. Then the platelets have granules inside them. They are going to release their granule contents. And the purpose of the granule contents, there are many purposes for the granule content, but the most important one is that they release certain chemicals, certain proteins that attracts more platelets to the site of injury. And it also helps the platelets to combine with each other. When the platelets, they combine with each other, we call it platelet aggregation. And this finally leads to the formation of a platelet plug formation. All of these steps, platelet adhesion, shape change, granule release, more recruitment of the platelets at the site, and finally formation of the platelet plug due to platelet aggregation is known, collectively it is known as primary hemostasis. Okay, so there are two steps in primary hemostasis. Number one was vasoconstriction. Number two is formation of the platelet plug. When the platelet plug formation happens, this is primary hemostasis is complete. Okay, so these platelets, they come into the site of injury and they will attach to the vessel wall. They will undergo shape change, secretion, aggregation, and they are going to form a plug. Now, if you understand this concept, then anything wrong with the vessel wall or anything wrong with the platelets will lead to primary hemostatic disorder. Okay, we will be discussing Majority of those in your year 3 hematology block, majority of those. Some I will point toward in the next few slides, but majority of them will be discussed in detail in the year 3 hemonc block, inshallah, semester 5. Right. Looking forward to it. Okay. At least share the smile. Not everybody share your smile. Okay. I keep forgetting that I'm getting recorded. Okay. So, and I will give you an example. If the platelets are low in number, we call it thrombocytopenia, right? We call it thrombocytopenia. So that means that the patient will have an increased risk of, because which pathway is now affected? The primary hemostatic mechanisms are now defective. If the platelets are there, but they are not functioning normally, then that will be another example of a primary hemostatic defect. Now, if they're not functioning normally, there can be two reasons. Either there is something wrong with the genes, inherited disorder. Examples include Glanzmann and Bernard-Soulier syndrome that was discussed in HLS. They are coming up in the next picture, inshallah. And can you give me one example that can lead to it if they are on certain kinds of drugs? Any drug that comes to mind? Aspirin, very good, aspirin. What does aspirin do? It inhibits thromboxane A2, and thromboxane A2 is a potent platelet aggregator. So somebody, Dr. Abrar has, I think, covered this with you, the cyclooxygenase pathway. Thromboxane A2 comes in cyclooxygenase pathway. No, I'm sure both of them covered it. I'm 100% sure both of them covered it. Okay, so if the platelet, if somebody is on a drug that is going to inhibit platelet aggregation, and there are many other drugs, clopidogrel, and I think it's going to come up anyway, they are all going to lead to a primary hemostatic defect, meaning the patient has a tendency to bleed more. Why? Because they are on a certain kind of drug. Is this clear? Any questions? Moving on. Now, platelets have two kinds of granular alpha and dense bodies. They have different constituents. You don't need to remember all of this. Honestly speaking, the only reason they are in red is because I'm going to talk about these things. The color coding is not because it's important. It is for me so that I don't forget. I don't write too much on my slides. It is for me so that I remember to tell you what is the importance of this redness. Don't worry. If it is important, I will tell you it is important, and if it is going to come in the exam. Okay, don't worry about it. But the volume factor is coming up on the next slide. The calcium is required in a number of steps in the clotting cascade. So one side from where the calcium is going to come is from the platelets. And I will show you, inshallah. Now, when the platelets, they adhere to the vessel wall, this is an interaction. These round golf-like things, these are the platelets. This is an interaction between a protein which is on the surface of the platelets. We call it glycoprotein 1b. And this glycoprotein 1b, it combines with von Willebrand factor, and this von Willebrand factor is released from the viable palate bodies in the endothelium. Okay, so the glycoprotein 1b, it combines with the von Willebrand factor, and this is what is known as platelet adhesion. The platelet adhesion is mediated by the interaction or interplay between glycoprotein 1b and von Willebrand factor. This is platelet adhesion. That means if glycoprotein 1b is not there, if somebody has an inherited deficiency of glycoprotein 1b, then this platelet adhesion will not happen. And this is an example of a primary hemostatic defect. We call it Bernard-Soulier syndrome. We call it Bernard-Soulier syndrome. It's a very rare disorder, but we call it Bernard-Soulier syndrome. The second thing is that the interaction of platelet aggregation is dependent upon glycoprotein 2b3a complex, again on the surface of the platelets, and they combine with fibrinogen. And this is how the platelets, they aggregate with each other. Fibrinogen is clotting factor 1. Okay, there are 13 clotting factors, more or less, and the fibrinogen is clotting factor 1. So the interplay between glycoprotein 2b3a protein, which is on the surface of the platelets, and fibrinogen promotes platelet aggregation, combining of the platelets with each other. So we call it platelet aggregation. Once again, if glycoprotein 2b3a is not there, this will be an example of a platelet function disorder, and it will be an example of a platelet, of a primary hemostatic defect. And that disorder, again, a very rare disorder, is known as Glanzmann thrombasthenia. Glanzmann thrombasthenia. Third disorder is von Willebrand factor. If the von Willebrand factor is not there, This is an example of both primary and secondary. Can anybody tell me how? It carries factor 8. Very good, Shima. So number one, von Willebrand factor is important for platelet adhesion. If von Willebrand factor is not there, then the platelet adhesion is going to be defective. It is not going to happen. So that means it will lead to a primary hemostatic defect. But in addition to that, a more important role for von Willebrand factor in the plasma is it is a carrier for factor 8. And factor 8 is one of the most important factors in the intrinsic pathway of the clotting cascade. I'll show you in a couple of diagrams, probably in the next one. So all three of these are examples of a primary hemostatic defect. Well, actually, two of them are really examples of primary hemostatic defect. Von Willebrand factor deficiency is an example of both primary and secondary hemostatic defect, and that's important. Either I will ask you here or I will ask you in Hemong block. I don't know where I will ask, but this question is coming. It always comes, okay? So von Willebrand factor deficiency is an example of both primary and secondary hemostatic defect, okay? So why is this important for you? It is important. Why are we discussing all of this? Number one, I've discussed some platelet function disorders, and I have given you some cues about von Willebrand factor deficiency or von Willebrand disease, okay? So as you are becoming physicians, you can take that basic knowledge and we can apply it in our clinical context. And this is where the pathology happens. If the glycoprotein 1B is not there, but not Sullier syndrome, glycoprotein 2B3A is not there, Lanzmann thrombasthenia, von Willebrand factor deficiency, this is all going to be related to it. From the pharmacology perspective, there are a number of platelet inhibitors. You have given me an example of aspirin, all the rest, clopidogrel, you don't need to remember all of these names. This is not part of your pharmacology objective. I'm just giving you examples like FCC-MAB and almost all of them, they invariably inhibits glycoprotein 2B3A. So if something is inhibiting glycoprotein 2B3A, that means platelet aggregation will not happen. And if the platelet aggregation is not going to happen, then that will be an example. And please listen carefully. This is a key word. This will be an example of an acquired platelet function defect. This is an acquired. Why are we calling acquired? Because we are the ones who are giving the drug. So there is nothing wrong with the platelets. It's not an inherited problem. It's an acquired problem. And how have the platelet acquired it? Because we are the ones who are giving the drugs. So this is an example of an acquired platelet function defect. I have given this MCQ so many times and students have not, well, about 60 to 70% of the class gets it. So I've now started stressing it more and more in the class. I hope you guys are listening, and I'm also being recorded. Doesn't mean it will come again. We have a huge number of MCQs. Some of them will come, some of them will not come. But at some point in time, while you are here, inshallah, this concept will be tested, either in this block or in the Hemong block. This concept, and again, don't go with the color coding, guys. This is only for me to explain a concept. These drugs are not part of your block. So don't email me asking me whether you want to know. The concept that I'm trying to convey is the reason we are discussing this, the normal physiology, you take that concept and you apply it in your clinical practice. And this is the importance for you. This is the reason we are discussing it. Understood? You need to ask this question in all lectures. Why? What am I studying? Why is this going to be important once I'm practicing as a physician? Because we are not training you to become an anatomist or an immunologist or a microbiologist or a pathologist. We are training you to become a physician or a doctor. So you have to ask this question, what am I studying and how can I apply in my daily practice? Okay, I'm going really slow today. Some of you are wondering, really, if this is slow for Dr. Raihan, what is fast? I'll show you. The third part, after vasoconstriction and primary hemostasis, I like this class, so I'm going slow, that's fine, is secondary hemostasis. Secondary hemostasis is, what is secondary hemostasis? Formation of the fibrin plug, okay? The end point of secondary hemostasis is we want to stop the bleeding, right? So the body is going to activate the clotting cascade, and the clotting cascade is ultimately, it is going to lead to the formation of a fibrin plug. Usually after trauma, the tissue factor that is released from the endothelium, it is going to start the extrinsic clotting cascade, which is coming up probably in the next slide. And it is going to lead to finally to the formation of this fibrin plug, okay? Some other important points here is you can see that the platelets, they underwent a shape change. So on this surface, they are also providing a phospholipid surface on which are required actually for the clotting cascade to act. So this is one function of the platelets, and that's why the primary hemostasis happens first. Immediately, when the clot is formed, when the thrombus is formed, when the bleeding is stopped, what starts happening immediately? Body's anti-thrombotic systems or fibrinolytic systems gets activated at the same time. And they are there because we don't want this clot to remain there for the rest of our life, right? We want this clot to go away once the bleeding has stopped. So for that reason, there are two major pathways, which we will discuss, inshallah, which are there to, number one, stop the further formation of thrombus. Number one, to stop the further formation of thrombus. And number two, what the thrombus is formed, it is there to lyse it, to digest it, to take it away. Okay, all of us have suffered maybe a cut or trauma in our life, and every time we have it, we find a fibrin plug being formed. We call it a scab, and then after a few days later, it's no longer there. You don't even remember it, that you had an episode of bleeding. So all of that happens due to the fibrinolytic pathway. Having said that, this is what happens normally, but we are not going to discuss normal things. This is just a review of the normal things that we covered in the HLS block. We are going to take that knowledge and we are going to apply it in pathology now. So in order for that to apply, an inappropriate activation of this fibrinolytic system or thrombotic system is going to lead to more and more clot formation. Okay, and how that happens, we will discuss it. Any questions? Thank God. Okay, all of the clotting factors are produced in the liver. Okay, and they are all formed in the inactive form, and their activation requires exposure to the activating substance. In this case, it can be the tissue factor for the extrinsic pathway, phospholipid surface, and calcium. Who is providing this phospholipid surface and calcium? Platelets. So some of you are awake, right, Nancy? I wish I knew some other names. Okay. So this is our clotting cascade. You are not supposed to remember. Please don't email me asking me whether you need to remember the sequence. No need. The concepts, yes. So the concepts are the extrinsic pathway is easy. Whenever there is tissue injury, it is going to release to the release of tissue factor. Another name for tissue factor is thromboplastin. It will combine with factor 7, leading to the formation of tissue factor 7A complex. So the factor 7 will get activated. The A indicates the factor is now activated. So tissue factor 7 complex is the only step in the extrinsic pathway. That's it. Tissue factor release combines with factor 7, forms formation of tissue factor 7A complex. That's it. That's the extrinsic pathway. The intrinsic pathway keeps on happening more or less all the time in our body because as we are walking or doing things, the minor amount of trauma that is happening. And it starts with the factor 12, which is the Higman factor. Once that gets activated, it is going to convert factor 11 to 11A, 9 to 9A, and 8 to 8A. Over this 8A is carried by which factor? Von Willebrand factor. So if the von Willebrand factor is not there, factor 8 will be destroyed very, very quickly. So it will not be there, and this intrinsic pathway will be affected. So von Willebrand disease is an example of both an intrinsic or a secondary hemostatic defect and a primary hemostatic defect, because it is also required for platelet adhesion. Both of these factors, both of these pathways, they will start the common pathway, and this common pathway needs conversion of factor 10 to 10A. Factor 5 is a cofactor for the conversion of prothrombin to thrombin. Thrombin is factor 2, activated form of factor 2, and it has a very central role in the hemostatic mechanism. And I will show you in one of the pictures. And then finally, this thrombin will cleave the fibrinogen and form the fibrin. And then this fibrin will get cross-linked by the action of factor 13. Now, this is in a nutshell what the clotting cascade is. Okay. But what are the important concepts here? Important concept number 1 is the release of tissue factor. Why? Because that is what happens normally. But as we discussed in our last lecture on shock, remember? You do? That's shocking. Okay, so that was last week, and it wasn't even coming in the midterm. The complement cascade and the PAMs attack the endothelial cells and lead to the release of this tissue factor, and that starts the DIC. Okay, it also leads to the activation, the PAMs especially leads to the activation of the Hegeman factor, and that will also going to, so we are taking the normal concepts and we are applying it in our clinical scenarios. This is what I'm doing. The second important concept is look at this: calcium, 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 and calcium. These four reactions, you don't need to remember the four steps, but please do remember that calcium is required at a number of places for the fibrin clot to form. Now, I will give you just one example, just to keep things simple. When we are taking somebody's blood for testing, okay, for example, for PT and APTT in the laboratory, we mix the blood with sodium citrate, okay, and this citrate is going to combine with calcium in the blood, and this is going to prevent the blood from clotting. Okay, so this, why this, if we remove the calcium from the blood will not clot. Why will it not clot? Because calcium is required in many steps in the common pathway. That's concept number one. Concept number two is, you can see this yellow thingy. Do you see this yellow? This is the phospholipid surface. These steps require a phospholipid surface. So please remember these three concepts. Number one was release of tissue factor. Number two is calcium is required in a number of steps. And number three, platelets provide a phospholipid surface. So these three are the core concepts that you should know in relation to the formation of the fibrin plug. This formation of the fibrin plug is also known as Tala. This is also known as secondary. Yeah, just to wake you up and you look bored. Next question will be to Salma. I forgot her name. Is it Serene? Yeah, I'm gonna, yeah. Nancy, don't worry. I found some people to pick on who are right here in the front row. Any questions so far? So this formation of fibrin plug, this formation of fibrin can be measured by two investigations. We call them the PT-INR and APTT. Okay, prothrombin time, INR stands for International Normalization Ratio, and APTT stands for Activated Partial Thromboplastin Time. So PT and INR, PT-INR is required to measure the extrinsic pathway and the common pathway. PT-INR is there to measure the extrinsic pathway and the common pathway. APTT is there to measure the intrinsic pathway and the common pathway. Okay. Now, the end point of these two is the formation of the fibrin plug. So we take the patient's plasma in these tube, these blue top containers. These blue top containers contain sodium citrate. The citrate is going to combine with calcium and prevent the clotting of blood. We will centrifuge the sample, we will separate the plasma, and in the plasma, we will add some constituents. Depending upon what we are adding, it will become either a PT or it will become a APTT. It depends upon what we are adding, okay? If we are adding thromboplastin, and you remember thromboplastin was another name for tissue factor, so the N plus calcium, then it is going to start the intrinsic pathway, and this will be an example of PT, okay, prothrombin time. If we add something else plus calcium, then it is going to lead to the activation of the intrinsic pathway, ultimately leading to the formation of fibrin plug, and we will call it an APTT. So there are three scenarios, and this is really important. Please remember these three scenarios. I think I have covered it in HLS, but I'm going to reiterate them today. If somebody has a prolonged PT, prothrombin time only, their APTT is normal and their bleeding time is normal, then it is very likely that either the patient is on drugs like warfarin, we are giving them warfarin, or any warfarin analogs, well, usually warfarin. And, or if they are not on any drug, then they can be suffering from factor 7 deficiency. If there's a child with a bleeding diathesis, everything else is normal, but only the prothrombin time is prolonged, then they can have factor 7 deficiency. That's scenario number one. Scenario number two is PT is normal, APTT is prolonged, okay? So if only APTT is prolonged, then it is very likely that the patient can have factor 8 deficiency, which is hemophilia A, or they have factor 9 deficiency, which is hemophilia B, or they can have factor 11 deficiency, which is hemophilia C, or they can have factor 12 deficiency, because all these 4 factors are in the intrinsic pathway. But the most common one, and it's a very common question in USMLE, they will give you a scenario of a young boy, and they will give you the lab investigations. Everything will be normal, the CBC will be normal, the PT will be normal, only the APTT will be prolonged, and they will ask you a question, what is the diagnosis? Remember, it's an X-linked disease, so the diagnosis, and there will be the options of factor 8 deficiency, hemophilia A, hemophilia B. The correct answer is hemophilia A. Do you know why? It's the most common. Who said that? You said it?
You said us. You told us this story.
Alhamdulillah. And you guys remember, how much of an impact am I having if you remember something? You guys usually say, we don't remember once the blog is over.
I really know you were the first.
Okay, Alhamdulillah. Remind me if I'm okay, if I'm telling you a joke that I've already told you, so interrupt me. So that the third scenario is that both PT and APTT are prolonged, and that would indicate a problem in the common pathway. So factor 1, 2, 5, and 10. 1, 2, 5, and 10. Okay. For factor 13, it acts after the fibrin clot is formed, so neither PT nor APTT is going to measure it. Has Dr. Dilip covered with you guys the concept of INR?
No.
Okay, INR stands for International Normalization Ratio. This one, international. So patients who are on warfarin, for them, we do the PT, prothrombin time. And what we do is we need to normalize it so that if they are taking it, for example, here in Riyadh, and then they travel to Canada or America or UK, wherever, and they get the PT test repeated over there, we use a kind of calculations to calculate their ratio, okay? It's a little bit complicated. I will just mention it. It's not part of the blog, so you can zone out. I don't mind. But it is the PT of the patient divided by the PT of a control sample, and then we raise it to the value of ISI. ISI is the International Sensitivity Index of the reagent thromboplastin that we are using to run this test. What happens with this is it gives us a ratio, and this ratio is required for us to tell the patient that they need to maintain their INR between this level. So I will give you one example, again, taking the normal thing and applying in our clinical context. Imagine a patient has a valve replacement. Their cardiac valve, aortic valve, let's say, has been replaced. So they need to prevent clotting from happening. So they will be put on warfarin. But at what level with this warfarin needs to be given so that it is clinically effective? So we will give them that we need to maintain their INR between 2 to 2.5 or 2.5 to 3. That means this much the INR needs to be raised for the drug to be clinically effective. Understood? So for this reason, whenever they run the test, they will see, okay, INR is now 1.7. We need to increase the dose. Okay, now INR is 2.5. Okay, you are in the therapeutic range. We will maintain you on this dosage. INR is 4. That's too high. Reduce the dosage, stop it for a couple of days, restart, repeat the test. So these are the clinical concepts that inshallah, probably you will be learning in year 5. Where are the clotting factors produced? Which organ? Liver. So if the liver is gone, I mean gone in the sense that it's not functioning normally due to cirrhosis or liver failure, then which test is going to be prolonged? PT or APTT? Both. Both. But your concept is based upon something very nice, actually. Both will be prolonged, but we monitor the patient with PT, actually. So you're not wrong, but both will be prolonged, okay? Patients in DIC will have an increase in both PT and APTT. Once we come to the part where DIC is discussed, I will tell you why. But usually because all the clotting factors are consumed for the production of the microclots, for that reason, both PT and APTT are going to be high. Factor 7 deficiency and as part of a pre-op screening panel. APTT to monitor patients who are on unfractionated heparin, patients in whom we suspect factor 8, 9, 11, 12 deficiency to evaluate a patient who's in. So in liver failure, both PT and APTT are going to be prolonged. And in DIC, both PT and APTT are going to be prolonged. Is this clear? Okay. Thrombin has a central role in coagulation. And thrombin causes a number of things. Number one, it generates fibrin by cleaving fibrinogen. Also activates factor 13 It also activates platelet aggregation and thromboxane A2 secretion. So it is required. So thrombin has a central role. So it is required in a number of factors. It is required for primary hemostasis. It is required in secondary hemostasis. And therefore, it carries a central role. Okay. So now we have direct thrombin inhibitors, which are heparin analogs, which are available. Is that lecture a part of this block, POD? Are you going to cover warfarin and heparin? Any idea? Has it been covered yet or not? Okay. So we will touch upon both, but not as part of the block, but as part of this lecture. So just a very brief overview of those, because I think they will be covered in the CVP block in semester 5 or HEMONC block or both, somewhere like that, or maybe in this block. I don't know. Moving on. That completes hemostasis. Once the clot is formed, we don't want the clot to be there for life, right? So we need it to go away. For that, we have two things. One is known as cascade inhibition, and the second is known as clot lysis. Let's do the clot lysis first. Clot lysis means the thrombus that is formed needs to go away, right? So for that, we need a conversion of plasminogen to plasmin, and this plasmin is going to digest the fibrin clot. This conversion of plasminogen to plasmin, these are proteins in the plasma, requires TPA or tissue plasminogen activator. And this, in a nutshell, is what we call the fibrinolytic pathway. Fibrinolytic means fibrin is there, we are going to lyse it. So fibrinolytic, okay? What is the key enzyme or key protein here? It is TPA, tissue plasminogen activator. Tissue plasminogen activator is going to convert plasminogen to plasmin, and plasmin is the protein that is going to digest the clot. Okay. Now it has great clinical significance. This was normal physiology. I'm going to take it a step further, and I will give you 3 examples. Maybe they're coming up, but anyway. Example number 1, we now can give tissue plasminogen activator, TPA, or its analog, or their analogs. There are many names for them. Streptokinase. Have you heard the word streptokinase and urokinase? Some of you are saying yes, some of you are saying no. Those who are saying no are lying. Why? You know why? I just mentioned it. You just heard it from me. So streptokinase, urokinase, and TPA, they all convert plasminogen to plasmin. And we give them in patients in whom we are suspecting what? Yes. So thrombotic strokes. Thrombotic strokes. Somebody has developed a thrombus in their cranial circulation, brain circulation, and that is leading to a stroke formation. Then we are going to give them this to lyse the clot. They can also be given in some cases, not all, in some cases of acute myocardial infarction if the patient is presented at a very early stage. They do not function if the patient comes to the hospital after a long period of time. So this is one clinical example. Second clinical concept, very important concept, is this. Do you see this? FDPs. So when fibrin is lysed, it will digest into smaller components. Okay. So we call them fibrin degradation products, or FDPs. What do we call them? Fibrin degradation. Why do we call them fibrin degradation product? Because they are the products of the degradation of fibrin. Okay. Don't make it complex. Keep it simple. Okay. So we call it fibrin degradation products. One of the fibrin degradation products is also known as D-dimer. Have you heard the word D-dimer?
Yeah.
How?
PBL.
Oh, in the PBL. Which PBL? Oh, in the shock PBL?
Yeah.
Okay. Well done. Alhamdulillah. Okay. So D-dimer is one type of fibrin degradation product. Am I right?
Yeah.
Okay. Who said yeah? Oh, that was a very... But what is the significance? Why am I discussing this? So this is normal, but they will be high in patients who have DIC. They will be high in patients who have DIC. Recently speaking, in the COVID situation, we have seen patients who have gone into shock, COVID shock and multi-organ failure, they have really high D-dimer levels. Okay, because all the things that we discussed in the last lecture, the shock pathophysiology, is happening at an increased rate in these patients. Moving on. It's a good thing you're recording it. I don't let a voice record it if I'm already recorded here. You know why? Because some of you are going to compare what I did here and what and sometimes I forget. The other system is clot or cascade inhibition system. So there are certain proteins or in the plasma that inhibits the clot formation. So now the clot is formed. We don't want these proteins, the clotting cascade, to keep on functioning, right? So protein C, protein S is a cofactor of protein C. It is going to inhibit factor 8 and factor 5. Antithrombin 3 is going to inhibit a number of factors, and tissue factor pathway inhibitor is going to inhibit what? Tissue factor. Okay, as the name indicates. So these proteins are there to inhibit further clot formation. Agreed? So once the clot is formed and the bleeding has stopped, this is really important. There are two mechanisms. One is there to lyse the clot. We call it fibrinolytic pathway. The most important protein in the fibrinolytic pathway is the conversion of plasminogen to plasmin through TPA or tissue plasmin activator. Then these protein C, protein S, tissue factor pathway inhibitor, and antithrombin 3 are there to inhibit the activated forms of all these clotting factors, and that prevents further clot formation. That is normal physiology. Let's take this concept and put it into pathology. If these proteins get activated, or if these proteins are not there, for example, protein C is not there, or protein S is not there, or antithrombin 3 is not there, what will happen? A lot of clot formation will happen, and these disorders are known as thrombophilias, prothrombotic states. Okay, well done. Those who understand it, fine. Those who do not, they will, inshallah, either today or next. So the reason this is important, what we have discussed, is if protein S is not there, then that is going to lead to thrombophilia, or with the interplay of some factor, thromboembolism. There are a number of anticoagulants like warfarin or heparin or low molecular weight heparin or fondaparinux. Again, they may be in different color, but they are not part of your pharmacology objective. The only concept I'm trying to convey is that the importance of understanding the concepts that we have discussed today. So if we understand how hemostasis is happening, then we can give the drugs to inhibit the normal hemostasis. We need to give it. I've given you the example of heparin, of warfarin. Heparin binds to antithrombin 3. The function of antithrombin 3 is to inhibit activated forms of different factors. Warfarin is going to potentiate this action by 1,000-fold. It is going to increase the action of antithrombin 3 by 1,000-fold. This is how heparin, the unfractionated heparin, works. So that means that they are going to inhibit a lot of activated factors, all these factors that I showed you. And that means it is a very potent anti-thrombotic agent. And it is very, very frequently used. And this is the reason it is used. So we have taken the physiology, we have applied some concepts in pathology, and I've told you the importance of that in different clinical aspects. Clear? Which slide am I on? What is the number of slide? Oh my God. Really? It's not 35? How slow have I gone today? Let's discuss 2 more slides, and then we will still start from thrombosis. Because I only have 1 more hour left, and I have so much to cover. Okay. What is thrombosis? No, not interested. I have to cover. I used to cover it in 3 hours 2 years ago. And I said, no, I need one more. If I go back and ask for 1 more hour, they will ask, what are you doing in the class? Tell me. What is thrombosis? Formation, pathological formation of an intravascular blood clot. 3 minutes more. We will finish at 8:50, according to the other watch. This watch, yeah. 2 minutes more. The pathological formation of an intravascular blood clot. If the clot is forming in the arteries, we call it arterial. If it is forming in the veins, we call it venous. What is the difference between a thrombus and a clot? The main difference, there are many differences, but the main difference, the easiest difference to remember, is that we call it a thrombus if it is forming in a living organism, living person. If it happens after death, we call it a clot. So some of you may have seen the sacrifice, what do you call it? Zabiha, when you cut the goat or cow or whatever, and when the blood flows, it clots. That's a clot. We don't call it a thrombus. But if somebody is having a myocardial infarction, God forbid, my father had it 3 days ago. Yeah, anyway, he's fine. Alhamdulillah. Yeah, he's fine. He underwent an graphene angioplasty. Yeah. So the obstruction of the coronary artery, we don't say that it is a clot, we call it a thrombus. That's the difference. Okay, when it happens in a living person, we call it a thrombus. Now, this is really a very semantics really between clot and thrombus. All clinicians use these terminologies interchangeably. Most common clot formation is deep venous thrombosis in the lower limb below the knee. And there are three factors combined. We call them Virchow's triad. What is Virchow's triad? It is endothelial injury, abnormal blood flow, and hypercoagulable states. All three of them together is known as Virchow's triad. And we will start from slide number 28, and we will go up to 70. Well, 69, in fact. Okay, guys, get ready for attendance. Somehow we will finish, inshallah. It's 9S48 Terminator 3. Any questions in the today's lecture? Alhamdulillah. You guys are so traumatized by the amount of, oh, I need to stop the recording first. You guys no longer ask any